Hello, my name's Dr. Leon Creaney. I wanted to talk to you today about the subject of tendinopathy. Obviously, in previous years, we've met in person. However, things are considerably different this year. And obviously, we're now doing this lecture online due to current circumstances. So we won't get to meet in person. Let me introduce myself. I'm a consultant in sport and exercise medicine, working mostly in private practice, the British athletics team, and also in football. And I've got a keen interest in sports myself, particularly running, which is what gave me my original interest in tendinopathy, particularly Achilles tendinopathy, which I've been managing in myself since 2007. So there's the man himself, Achilles. It was said that his only weakness was his heel, and if you'll excuse the pun, many other runners have followed in his footsteps. So we're going to try and cover quite a lot of content in this session. Briefly overview normal tendon structure and the mounting evidence of the inflammatory involvement of inflammation in tendinopathy. Quickly looking at some or other aspects of basic science and imaging before moving on to the various treatments that have been proposed in managing tendinopathy. So obviously it's a very common disorder. All of these different areas of the body suffer from their own version of tendinopathy. Because of historical factors, they've all ended up with different eponyms and names, but actually what we're looking at is often the same underlying condition, namely a tendinopathy. So I wanted to begin by dealing with what is the pathology that we see in tendinopathy, and that's difficult to understand if we don't know what normal structure is. So there is a spectrum of normality in tendons, which we need to appreciate, is that particularly in competitive athletes who are logging up high training loads, tendon structure will vary enormously between active controls and sedentary people. As you can see here, collagen alignment is often different. We see changes in the ultrasound echo texture, changes in thickness, and so on and so forth. So we've come to recognize a new category of tendon here, the so-called habituated tendon, which may be pain-free, but is different from a non-runner's tendon. What is normal tendon made of? Just a quick revision here. The most important thing to understand is that they're 90% type 1 collagen, which has a high tensile strength. There are other aspects of type 3 collagen in there, which particularly is expressed in damaged and healing tendons. It appears to be a type of collagen that is easier and quicker to make, but not as tough, and disappears as tendon structure matures. There are other cellular and non-cellular components, such as proteoglycans and the occasional scattered cell. Specialized fibroblasts do exist within tendon structures and have been named tenocytes, and there are also pluripotent stem cells. There's normally very little vascular or neural tissue within the substance of a tendon itself. Blood supply is of clinical interest. Normally, intratendinously, there is very little blood flow, although, as we know, this does change in pathological tendons. So what kind of pathology do we see in tendinopathy? Well, carbon dating has been used to demonstrate collagen turnover in tendinopathy and it's been demonstrated that increased collagen turnover often precedes the onset of clinical tendinopathy by many years. The classic model of tendinopathy is one of exercise-induced collagen damage and failed repair and remodeling, though we know other factors are involved now as well. As I've mentioned earlier, tendon blood flow is very important. Tendons are known to have a poor blood supply and often contain these watershed vascular areas that can become ischemically injured, particularly when under repeated tensile strain, and reperfusion injury may lead to injury via various mechanisms, leading to tenocyte apoptosis. Collagen is very tough, though we know if it's taken beyond a comfortable level of strain, it will rupture. There is a sweet spot for loading of tendons, which is anabolic, but if we take collagen elongation beyond that, we know we will damage it, and there is a limit to musculoskeletal tissue's potential for remodeling. If it goes beyond that, we can over exert the system. In early tendinopathy, we start to see increased disorder of collagen. We see an increase in the proteoglycan content of tissues, in particular aggrecan. This is a hydrophilic molecule, and it draws in water, which is thought to be one of the reasons that tendons swell as they become pathologic. We also see changes in the cellular components of tendons, with changes in the shape of the tenocytes to a more immature and active form. And again, we see an increase in the non-favourable type of collagen, type 3 collagen, which is a more immature and less robust type of collagen within the tendon. And finally, reduced collagen crosslinks, which add to the strength of a tendon. We see here various stages of tendinopathy under extreme magnification with the electron microscope. As the tendon becomes more disordered, the gaps between collagen fibers increase, and we start to see increased amounts of non-collagenous extracellular matrix. And greater glycosaminoglycan content is certainly well correlated with tendinopathy, and there is a loose relationship between increased glycosaminoglycan content and pain levels that people experience. This study here nicely showed how glycosaminoglycan content correlated with the VISA P score in patellar tendinopathy. And then with some specialised immunohistochemical staining here, they were able to show the aggrecan content loosely plotted against the VISA score, this time in Achilles tendon samples. And we can see here increasing levels of green stain for the aggrecan, correlating quite nicely with falling VISA scores, indicating increasingly symptomatic tendons. I mentioned it earlier, vascular considerations are important in tendinopathy. The so-called watershed area within an Achilles tendon is in the mid portion. Its blood supply appears to be somewhat more patchy than in other areas of the tendon. This was a study done in Belgium, where they looked at students in the development of Achilles tendinopathy and its relationship to the blood flow within a tendon during and after exercise. And they were able to demonstrate that those students whose ability to increase blood flow within the tendon was poorer were more likely to go on and develop tendinopathy. We see the classic model from the Cook-Purdon paper here, describing tendinopathy as a continuum. In other words, a gradual change from a completely normal and healthy tendon through to what's known as reactive tendinopathy, where there's no real underlying type 1 collagen damage, but we're starting to see inflammatory cellular components and increased extracellular matrix. Then eventually we come on to tendon disrepair, where we do in fact see collagen damage, and eventually degenerative tendinopathy, where there's significant collagen damage which is irreversible, increased permanent proteoglycan content, and swelling and water within the tissues. It's believed to some extent that people can move back and forth along this continuum, though the further you go towards tendon degeneration, generally seen in older athletes, the condition eventually becomes not completely reversible, and there will always be a degree of tendinopathy no matter how well it's treated. So the emphasis does tend to switch from cure to management in older athletes. So in reactive tendinopathy, we see very little disorganization of the collagen fibrils, but we do see the increased proteoglycan content, and we believe this to be fully reversible, often simply with rest. These changes can actually be tracked in athletes live in real time using an ultrasound technique called ultrasound tissue characterization, UTC. And we see some changes here in a reactive tendon. This is a cross-section of an Achilles. Green pixels are high quality collagen, blue pixels slightly less quality, and we can see 2 days after a hard training session slight reactive tendinopathy in the tendon on day 2, but by day 4 it's already beginning to improve and resolve. This does show the importance of cycles of loading and rest for tendon pain management. So in summary, tendon pathology, we do see evidence of vascular reperfusion injury mediated damage, many years preceding, in some cases, of increased collagen turnover before onset of symptomatic clinical tendinopathy. The primary pathology appears to be collagen disorganization, and also increased proteoglycan content, and finally changes in the cellular component with signs of tenocyte or fibroblast stress. So I haven't really mentioned inflammation yet, and we'll move on to that in the next section. So in recent years, inflammation has once again become of interest in tendinopathy. For a long time, we've referred to the condition as tendinopathy rather than tendinitis, but in future, who knows whether we may go back to that term. There's certainly evidence of macrophage and monocyte infiltration within tendinopathy, and also other cellular components involved in chronic inflammation, such as T cells and specialized T cells, such as natural killer cells. We also know that systemically introduced anti-inflammatories, corticosteroids such as dexamethasone, can reduce specialized T cell populations such as cytotoxic T cells in injured tendons, and this can lead to improved healing. Furthermore, we see very much increased inflammatory mediators such as prostaglandins, COX-2, and growth factors such as transforming growth factor beta, which is a growth factor heavily implicated in fibrosis, and pain mediators, neurotransmitters such as substance P. Recently researched and emerging molecules also include the alarmins, heat shock proteins, hypoxia inducible factor, so on and so forth, and then various pro-inflammatory cytokines such as interleukin 1 beta and interleukin 6. These are all found in increased concentrations within pathologic tendons. Some very early clinical trials have been done in animal models where they've used interleukin 1 receptor antagonists in rat Achilles tendon models with some success. But none of these have really entered human trials clinically. So there certainly is evidence of tendon inflammation in tendinopathy. It's not purely a mechanical wear and tear process. There may be an initial mechanical injurious initiating event, but this then leads to the onset of inflammation, which may further exaggerate the damage in a mechanically loaded tendon. Overweight, obesity, and diabetes are certainly heavily implicated in the onset of tendinopathy in certain populations. We know that tendinopathy, and in particular calcific tendinopathy, are more common in diabetics, and we know that tenocytes exposed to hyperglycemic environments have a tendency to differentiate into other cell types such as adipocytes, and this can lead to intratendinous lipid deposition. It can be ameliorated somewhat through mechanical loading. Adipose tissue can be a source of pro-inflammatory cytokines, and certainly increased adiposity leads to a low-grade systemic inflammatory response. It's also been shown that fibroblasts and myoblasts can be encouraged to differentiate into osteoblasts in pathological tendons, and this may be a pathway by which calcium deposition occurs in calcific tendinopathy. Another big question in tendinopathy is, where does the pain actually come from? My leading theory is that the pain is a side effect of the inflammatory component of tendinopathy, the failed remodeling and the attempt at repair. The body tries to heal through a mechanism of inflammation, but inflammation, as well as bringing healing, also brings along with it pain through various inflammatory mediators. This review paper from 2013 really covered all of the potential sources of pain in tendinopathy. There are multiple theories, but often it's just not clear. Tendon pain certainly seems to be a somatic pain because it's very highly localized, and the pain is largely a peripherally mediated pain rather than, as some people think, being a central sensitization phenomenon. There doesn't appear to be any relationship of pain to collagen structure. This has been shown over and over again that it doesn't correlate very well with grayscale ultrasound or even ultrasound tissue characterization. Though I've said earlier, there does seem to be a weak relationship with proteoglycan content. So one leading theory at the moment is that large proteoglycans, in particular aggrecan, do attract and bind water, causing the tendon to swell. This may in fact cause increased hydrostatic pressure on localized neural components such as C fibers, and maybe even increase intracellular hydrogen ion concentrations, changing the pH in the local environment, again stimulating local nociception. It doesn't really help us understand the question of why some pathological tendons become painful and then others don't. If inflammation is one of the key mediating factors in pain, then it might be that some people develop asymptomatic tendon degeneration because they mount very little inflammatory response to the injury, and these could be the people who develop these so-called spontaneous tendon ruptures, very degenerative tendons which suddenly rupture but with no real pain preceding it. And then there may be another class of patients who do mount an inflammatory response to the injury. These are the people who go on to develop painful tendons, often that don't rupture but become chronically painful. So that ends our section on tendon pathology. So I wanted to look at imaging now, in particular emphasising various techniques such as MRI, ultrasound and ultrasound tissue characterisation. So we have here an MRI of a abnormal Achilles tendon. This is what's known as a STIR sequence, STIR, which is short for short tau inversion recovery. Essentially, what you need to know about these MRI sequences is that they suppress the signal from all of the tissues apart from water itself, which is made to look white. And these sequences are very good for making pathology stand out and catch the eye. We can see a axial section, a cross section of the Achilles tendon there. We can see there is greying within the substance of the Achilles itself, but also some free fluid in the paratenon surrounding the Achilles tendon. And we can also see that it's thickened from normal. So we're seeing two pathologies here of paratenonitis around the tendon and also thickening and greying of the tendon itself, which is tendinopathy. There are more advanced MRI techniques. You can use a technique called sodium mapping, used on 7 Tesla scanners, where you can actually measure a proxy of the glycosaminoglycan content of tendons, and we can show here in increasingly pathological tendons increasing tendon sodium or glycosaminoglycan content. And these techniques, which aren't really used in clinical practice, are used to research tendinopathy. This is a conventional grayscale ultrasound, again of an Achilles tendon. Marked C there is the calcaneum, which is the Achilles tendon insertion, where the Achilles looks fairly normal, but you can see the mid portion, the tendon really balloons out to double thickness, and certainly on the posterior aspect of the tendon, the Achilles is very dark looking instead of retaining a good white collagen signal. If you look at it in cross section there, you can see instead of it being a nice white structure throughout, there's large areas of black where no good collagen signal is being retained. And then when you turn on the Doppler, you can see increased blood flow within the tendon, so increased microvascular activity, so-called neovascularization, which is one of the hallmarks on ultrasound of tendinopathy. This is a patella tendon. Again, you can see it's nicely thickened. And what we have here in the bottom left picture is a localized area of tendinopathy. You turn on the Doppler and you can see increased blood flow in that particular area. If you turn it off, you can see a tendinopathic area surrounded by normal collagen structure in the rest of the tendon. Now we have to be very careful that we don't assume all painful tendons are tendinopathy. There are other diagnoses, and if you're not aware of them, you will never see them. So remember that not all tendon pain is tendinopathy. Don't forget that some people will have a genuine inflammatory arthritis and may have genuine tendinitis. This can be seen in particular in association with inflammatory arthritis such as ankylosing spondylitis or other seronegative arthropathies, and this definitely shouldn't be missed. But another pathology that you really need to recognize and differentiate from tendinopathy is partial and intratendinous tears. Clinically, they do behave differently from tendinopathy. It's usually of more acute onset, and there is sudden sharp pinching pain on loading rather than the more diffuse pain that you get in tendinopathy. And what we can see here again in an Achilles tendon is a very localized area representing a interstitial tear, rather than the more diffuse and widespread changes that you see in tendinopathy. This is my own personal case history of sustaining a partial tear of my Achilles tendon. Often seen in people with a previous background of Achilles tendinopathy, but unable to do any kind of heavy loading of the tendon or high speed work. So if you look at this MRI, the Achilles is obviously quite thickened in its mid portion there, but not particularly greyed out. But you can see the lower marker there, an area of grey granulation tissue within the tendon, and this is a partial tear which is granulating and healing, and needs to be recognised as a separate entity to tendinopathy. This is the equivalent ultrasound picture, and again you can see that very localised area of black within an otherwise fairly normal looking tendon. One of the treatments used for this is prolotherapy, where you inject a mixture of dextrose and local anaesthetic into the injured area, and this encourages fibrosis and then is combined with a period of immobilisation in an air cast boot. Moving on to the third imaging technique in tendinopathy that I wanted to talk about, ultrasound tissue characterization. This essentially uses grayscale ultrasound and a computer, and it converts the pixels into a colour-coded picture. Good quality collagen sound waves will bounce straight back from and return a strong signal, which the computer codes as green. With increasingly poor return of signal, the computer codes the returning pixel as either blue, red or black. So a healthy tendon, we can see there, is of normal thickness, and with ultrasound tissue characterization will return mostly green and blue pixels, but a pathological sample there on the right we can see is thicker than normal with increased amounts of blue and red pixels. This can be used to track healing of injured tendons. We can see here, this is an injured horse superficial digital flexor tendon, and we can see on day 7 there a core injury in red. Gets worse as time goes on before it starts to heal. We can see it peaks 35 days post injury, but by day 84 is significantly improved, and by day 124 is almost healed. So it is used to track healing, particularly in research. And we can also see a weak relationship between pain scores, but the tendon pain often improves long before the tendon structure has been shown to improve. So moving on to treatments now. Just a quick note about experience-based medicine versus evidence-based medicine. Experience says that they've treated lots of patients, so they know what works. Whereas with evidence-based medicine, we try and be more objective, and in particular remove bias, and try to compare our treatments against placebo controls. Why is this important? Well, what we do know is that many conditions have a tendency to spontaneously improve anyway. So this blue line is a typical condition. We see that there's an injury, pain gets worse for a while, but then over time, pain and function tend to improve. If we don't have any comparator for this, we could think that any treatment that we introduce is genuinely effective. So if we add that red line now, this could be a treatment that we give, which apparently seems to work. It looks like it works at face value, but when we compare it against the natural history of the condition, we can see the placebo actually doesn't improve the condition any faster than natural healing does. If we then compare it against a truly effective treatment, we can see that the truly effective treatment outperforms both the natural history and the placebo, and it's the difference between the two that is the true treatment effect. This can't be seen with clinical experience. It can only be seen with placebo-controlled trials, which is why randomized controlled trials are important. You can see 10,000 patients, but you can never differentiate these two things without the power of placebo control and blinding. So we have to consider all of these things when we're looking at research and the quality of research. Placebo control, very important. Randomization, so that we can't pick and choose which patients we want to treat. Blinding, so that both the observer and the treater don't know which treatment was given. Prospective rather than retrospective. Follow-up and intention to treat, which means that we have to consider patients dropping out due to side effects of treatment and so on and so forth. Statistical power is really important to make sure that we don't include too few patients in the trial to make it too statistically weak. And removing bias, and also very importantly confounding factors, so other treatments that might be concurrently happening or other factors at play which we're not even aware of, which affect the overall results. And because of that, there is a hierarchy of evidence with systematic reviews of randomized controlled trials sitting right at the top. So, moving on to treatment. You'll all know that loading remains the most important treatment in tendinopathy. How does it work? Well, through a mechanism known as mechanotransduction. This is the conversion of a mechanical signal, such as lifting weights, into the following biological response. There's multiple examples of this in musculoskeletal medicine and even in training science. So, for example, resistance training will eventually lead to muscle hypertrophy. Eccentric loading will eventually lead to tendon regeneration, and even weight-bearing exercise will increase bone mineral density. There are multiple intracellular biological mechanisms that this is mediated by, for example, stretch-activated calcium channels, which activate downstream intracellular proteins, and they all eventually lead to the activation of DNA and transcription factors and the generation of new proteins. So what kind of exercise prescription do we give for tendons? Well, there are 4 variables that we can play around with. So there is the mode of contraction, eccentric, concentric, or isometric. Modern research seems to have denoted that there's little difference in the efficacy of these 3 modes of contraction. Eccentric certainly allows the highest loads and is therefore the most painful to do. Whereas concentric and isometric allow for lower loads but are often less painful to perform. So for very painful tendons, we often start with non-moving isometric contractions, and when the patient's a little bit stronger and able to tolerate it, we move on to concentric and then eventually eccentric. Duration of load is important, and as we'll see later, longer duration holds seem to be more effective. Force is important. Increasing amounts of force seem to be more effective, and again, number, and we can vary this by the number of sets and repetitions within a set. This trial from a while back now compared the effectiveness of corticosteroid injection against eccentric loading and heavy slow resistance training, so concentric or isotonic lifts in patellar tendinopathy, and they showed very little difference in the outcome between eccentric and concentric loading, What they did show with the corticosteroid injections is that there was an immediate but short-lived pain response which tended to wear off over time. So steroids can be useful for short-term pain relief, but they're not effective in the long term, and obviously they may damage tendons over time. This was a short trial that looked at the effect of duration of contraction in muscle protein genesis, and again showed that slow contractions, 6 seconds versus a second, seem to be more effective. And again, differences between the amount of loading, showing that heavier loads seem to be more effective than lighter loads. Again, the practical outcome of this is that patients begin quite weak and need to build the strength up over time. So in the initial stages of loading, we often give an exercise prescription of a large number of low load repetitions, for example 3 sets of 20 at a light load, but as time goes on we bring the number of repetitions down but increase the amount of strain by increasing the weight that is lifted. So eventually we may move down to a heavier lift, 3 sets of 10 for example. Time under tension is an important concept. So tenocytes seem to synthesize type 1 collagen better when the speed of contraction is slower. So we try and slow the stimulus down and increase the time under tension. This has been shown to increase the type 1 collagen formation. There can be too much stimulus, however, and after a number of cycles of loading, it seems that tenocytes become exhausted, so there's no further gain to be made by increasing the amount of loading after a certain point, but you can potentially do more damage. So it's not about loading progressively ever more. It's about finding that equilibrium point where there's enough stimulus made to produce an anabolic response without pushing a patient into a catabolic response because you overdo it. Now that point is going to be different from every person, and it does to an extent depend on the previous training background of the person. Athletes who are used to a very high training load are going to require a stronger stimulus to provoke a response than a novice who is not used to training. So the exercise prescription and the tendon loading prescription needs to be varied according to the individual. So this is just demonstrating that concept that there's a sweet spot with training. You can do too much, and in particular recovery is important. So whenever we apply an anabolic stimulus such as loading, there needs to be time for the tendon to respond and recover, and it seems that in tendons it takes them about 48 hours to produce the anabolic response and for the catabolic response to die down. So whereas tendon loading used to be encouraged on a daily basis or perhaps even on a twice daily basis, we now think that a stimulus every 48 hours is probably enough. This maximizes the anabolic or synthetic response of collagen, but minimizes any potential damage through overtraining. This slide just demonstrates that whereas most of the research is being done on eccentric loading, there's plenty of evidence that heavy, slow resistance training in terms of concentric loading is also effective. So this is a great paper to look at if you wanted some loading programs for your patients. easily accessible Achilles and patella tendon loading programs for clinical use. The bottom line is that over time, you need to get your patients to improve their capacity, increased strength of the relevant tendon. So, for example, an Achilles, increased strength and capacity of the ability to do calf raises. If it's a tennis elbow, common extensor origin tendinopathy, it would be increased strength and capacity to do resisted wrist extension, for example. So the Cook 4-stage model, we start with isometric exercises, not necessarily because they're proven to cause pain relief, although this has been thought of initially, but because it's probably the easiest and least painful to do for an amateur patient, then gradually improving the capacity, building up to heavy, slow resistance concentric training, and then eventually the most difficult exercises, i.e. eccentric. And once a patient has got good concentric and eccentric capacity, moving on to faster ballistic type exercises that improve the energy storage capacity of a tendon, so more plyometric work. And then when returning to sports specific training that may involve rapid change of direction and sprinting, we really do need to improve the plyometric capacity of a tendon before a person returns to sport. So that concluded the section on loading. And what about tendon nutrition? Well, there is some emerging evidence that supplementation can improve tendon health. In particular, collagen or gelatin supplementation. So this can be used as part of your rehabilitation of your injured patient. Vitamin C promotes absorption of collagen from the gastrointestinal system. So it's usually worthwhile if you're going to take gelatin, which is hydrolyzed collagen, or collagen supplements, to co-ingest them with some vitamin C to improve absorption. And this in theory could improve collagen synthesis if it's taken prior to a training stimulus. Just one trial here using a commercially produced tendon collagen supplement, Tendo Forte, showing the potential to enhance the rehabilitation. And the theory being that you increase the availability of the raw materials, which allows for better tendon collagen synthesis. Just one trial here showing this tendon collagen supplement, Tendo Forte, compared against a placebo nutritional agent, showing slightly improved Visa A scores in the Tendo Forte treated patients. And this was the exercise protocol that they used in that particular trial. So moving on to other treatments, I'm sure you've all heard of platelet-rich plasma. A lot of trials around PRP and a lot of conflicting evidence. So for as many trials that you can find that show a positive effect of platelet-rich plasma, there seems to be an equal number of trials that show no effect. This is probably one of the highest quality trials that was published in JAMA, which showed no effect or additional effect of PRP when combined with an eccentric loading program in chronic Achilles tendinopathy. And again, evidence against the use of PRP in tennis elbow here. But then an equal number of trials and even systematic reviews suggesting that there is some effect. This was a nice meta-analysis combining a large number of studies with an overall pooled result there at the bottom, showing a favourable outcome for platelet-rich plasma in tendinopathy. And again, a systematic review here published in BMJ Open Sports Medicine. Again, coming out in favour across 20 trials, the pooled result there favouring the effect of PRP in tendinopathy. So let's just look at some of the basic science in tendinopathy. Let's actually see if it does change anything about the structure of tendons. This was a specialised MRI technique using T2 collagen mapping in an injured rabbit Achilles tendon model. So what they did in this trial was they deliberately injured a rat Achilles tendon, sewed it back together and watched it heal. We can see the conventional MRI in the left picture there, increased T2 signal in the injured part of the tendon, and then the false colour collagen map there, showing various levels of quality of collagen within the injured part of the tendon. To summarise, the more blue that the tendon looks on this collagen map, the healthier the collagen is, and the more red it is, the less healthy the collagen is. So if we take a look at this slide here, the top slide is a placebo-treated rabbit Achilles, and the bottom slide, E, F, G and H, is a PRP-treated injured rabbit Achilles. And we can see at time point A, if anything, the PRP-treated tendon looks slightly worse in terms of its collagen quality. If we then compare the next time point, slide B with slide F, we can see that the PRP-treated Achilles appears to be healing somewhat faster, and certainly this is evident again at the next time point where we compare C and G, and probably again at the final time point where we compare D with H. And this is borne out in the numerical findings as well, is the 2 weeks post-operative period, 4 weeks, 8 weeks and 12 weeks. So on this second slide here, again we see the histological comparison between the specimens, the untreated tendon on the top row running from A to D, and the treated running from E to H. And again, we can see more ordered histology from the collagen in the treated samples, also borne out in the numerical ratings. One of the issues people worry about with platelet-rich plasma is speed of onset of effect. Obviously, steroids are very rapid in their pain relief action, whereas platelet-rich plasma, which works via a regenerative mechanism, may not provide the same instantaneous pain relief. This was a study done in osteoarthritic knees using the WOMAC score as their major outcome, and we can see how a platelet-rich plasma injection seems to outperform placebo even at the 1 week stage, and this becomes significantly different at every other time point, and in fact endures up to 12 months later. Bear in mind that this was a study done in arthritis rather than tendinopathy. So coming down to a few more studies here with longer term follow-up using various versions of platelet-rich plasma. This particular system, the Biomet system, is a leukocyte-rich high-yield platelet system, and this was a study done comparing PRP with corticosteroids in gluteal tendinopathy. And again, we can see the corticosteroid effect is quite rapid in its onset of action there within a week or two. But interestingly, the platelet-rich plasma also has that rapid onset of action. Not quite sure what the underlying mechanism of this is, but it's borne out in more than one trial. But then again, interestingly, steroids, which we know on average work for about 3 months, we can see the separation of the red and blue lines there, where the platelet-rich plasma starts to outperform the corticosteroid, and they remain separated at the 6-month, 12-month and 2-year stage. So in summary, there's really two broad classifications of platelet-rich plasma. There's the leukocyte-rich type, which is thought to be a more inflammatory type platelet-rich plasma preparation, and this one is advocated for use in tendinopathy, whereas the leukocyte-depleted and moderate platelet yield PRP is more in fashion for osteoarthritis. These recommendations are really only based on a small number of trials and could easily change again in the future. So there are more advanced versions of platelet-rich plasma now, where they've started combining the PRP with other substances. This is a product that combines PRP with a human recombinant type 1 collagen. The two substances are mixed and injected together directly into the substance of a damaged tendon. Just 1 or 2 trials on this at the moment. And then really moving on to even more in-depth systems. This is platelet-rich plasma being mixed with pluripotent stem cells extracted from adipose tissue, what's known as the stromal vascular fraction. And again, really only 1 or 2 case reports on this at the moment. This is a study done in tennis elbow using PRP combined with stem cells derived from adipose tissue. The theory here is that you concentrate the small number of pluripotent stem cells that are present in adipose tissue. So there is a long and drawn out concentration process. The fat has to be extracted via liposuction and then concentrated in several stages using the system and then mixed with the PRP before injected. Moving on to somewhat more old-fashioned and lower technology solutions, prolotherapy or proliferative therapy has been around since at least the 1960s. The underlying purported mechanism of prolotherapy is that it is pro-inflammatory. It encourages scar tissue formation by injecting an irritant substance into injured tissues. The usual irritant substance that's injected these days would be hypertonic dextrose, so 50% dextrose or 25% dextrose if it's diluted down with a local anaesthetic such as levobupivacaine. There's been a handful of trials on this over the years, pulled together into a meta-analysis showing positive findings. The pictures of the ultrasound that we're seeing here is a prolotherapy injection done into an intratendinous tear within an Achilles tendon. You inject the irritant solution directly into the tear to encourage fibrosis, and then you immobilize in an air cast boot to allow the healing. So where might the future lie? Well, tenocytes and cellular therapies are being looked at more and more. Tenocytes are specialist fibroblasts that sit within the structure of a tendon. We talked about them at the beginning of the lecture. So some early trials here using skin-derived fibroblasts for the treatment of Achilles tendinopathy. And again, we can see nice before and after pictures here of a clearly hypoechoic diseased Achilles tendon treated with direct injection of skin-derived fibroblasts, and then several months later, normal looking echo texture on the lower picture there. This is a case using autologous tenocytes into tennis elbow. And we can see 2 different cases here. of the MRI sequences. Patient A, before and after, you can see the high signal within the common extensor origin improving after tenocyte treatment. This is a case in a shoulder in a swimmer. It was actually an Australian Olympic athlete with a subscapularis injury, and we can see the different sections there: sagittal, coronal and axial. This athlete had already been treated with lots of other things and was resistant to improvement, and we can see the resolution of the injury at the different stages following tenocyte treatment. And here's a nice case of a gluteal tendinopathy before and after. Has to be said that tenocytes are quite hard to get hold of. They have to be extracted from the patient and then grown in commercial labs and returned a few weeks later for re-injection. And there's really only a couple of labs around the world that are doing this at the moment. Most of these studies have come from Australia. And of course, they're all single case studies, so we don't know what would have happened with these patients if they'd followed their natural history, because there is no control group for comparison. Some people have advocated hyaluronic acid, viscose supplements such as Ostanil in the use of tendinopathy. Again, the purported mechanism of action is quite tenuous. Hyaluronic acid may have some weak anti-inflammatory effects by binding to CD44 antigen positive cells. This is a cell surface marker that is present on many inflammatory cells. Just one or two trials in tendinopathy really using hyaluronic acid. This is an example of a trial where they've compared it against platelet-rich plasma. This was done in knees and showed roughly equivalence between PRP and hyaluronic acid, but unfortunately no control group for either. So looking at the outcome measure of interest, pain there, at baseline PRP and HA roughly in the mid-60s, improving at follow-up 2, 6 and 12 months up to 74.9. Obviously this is only really a 1-point improvement on the VAS scale, which may be of statistical significance but probably not of very much clinical significance. And again, comparison of peritendinous hyaluronate injections versus shockwave therapy seem to show greater improvement in Achilles tendinopathy than shockwave. Okay, so moving on, I wanted to talk about anti-inflammatories for a while. The reason being that their use in sport is ubiquitous. Obviously, ibuprofen is available over the counter, and other drugs such as diclofenac, naproxen and celecoxib are very popular in the UK and prescribed very frequently. So, non-steroidals obviously far less potent than corticosteroids in their anti-inflammatory action, working predominantly in the cell cytoplasm rather than in the nucleus, and certainly not inducing any genes to be activated. They work primarily by blocking the cyclooxygenase enzyme, and obviously there's believed to be these two different isoforms, COX-1 and COX-2, COX-1 being responsible for normal physiological cyclooxygenase activity, and COX-2 being more specific for when inflammation is present. And that's why the COX inhibitors, such as celecoxib, have been invented to be more gentle on the normal physiology of the stomach. But But all of these pathways can ultimately lead to activation of regenerative cells, such as in the muscle satellite cells, within tendons, tenocytes, and within bone, osteoblasts, and therefore blocking them may have a deleterious effect on tissue remodeling and regeneration. Other mechanisms by which anti-inflammatories may exert an effect in tendons is by their effect on matrix metalloproteinases. These are enzymes within tissues that break down various parts of collagen and facilitate remodeling, and there are also natural inhibitors of the MMPs known as TIMPs, tissue inhibitors of matrix metalloproteinases. Other drugs have an effect on these as well. You may have come across doxycycline in the past. This is actually known also to be a generalized inhibitor of matrix metalloproteinases. There's maybe up to 10 different MMP isoforms. Some drugs only block one or two of the isoforms, and other drugs, such as doxycycline, seem to block them all. So obviously, this is a very carefully balanced process. Tissue turnover is balanced by the action of these MMPs and TIMPs, and generally speaking, if we interrupt quite a carefully coordinated biological process with iatrogenic meddling, we could have a deleterious effect on it. So again, further potential mechanisms of NSAIDs on tendons. We can see here that there's evidence ibuprofen does inhibit tendon cell proliferation and can arrest fibroblasts through their cell cycle. You may have seen this paper, it's quite old now, 12 years old, where a group of non-medical non-pharmacological, mostly physiotherapists, recommended a cocktail of drugs for use in tendinopathy. For me, it's a good example of people straying out of their specialty and making poor recommendations, because as we can see, there's quite strong evidence that ibuprofen and doxycycline have a negative effect on tendons. So again, further evidence here that anti-inflammatories have a deleterious effect on collagen production within tendons. This was a trial where they looked at runners pre and post a stimulation of a 36-kilometer run, looking at collagen formation in the tissues in people who were treated with and not treated with a non-steroidal. And the take-home message from this slide is that the non-steroidals completely blunted the ability of the tissues to produce collagen post a exercise stimulus. So what about corticosteroids? Obviously, corticosteroids are synthetic man-made analogues of the human hormone cortisol. Separate from their anti-inflammatory mechanism, they have quite a potent analgesic mechanism, various potential pathways through which this could be mediated. Dexamethasone, for example, has been shown to reduce effects on nociceptive C fibers, so a direct effect on pain sensation there. This is an experiment that was done on rats where they were fed a corticosteroid in the water that they were drinking and then subjected to a painful stimulus. And the rats who had higher concentrations of corticosteroid seemed to have less response to the painful stimulus. Obviously, when it comes to tendons, corticosteroids usually get a bad reputation. This was a very high quality piece of research published in Science and Nature quite recently, where they demonstrated the correct and judicious use of corticosteroids could in fact improve musculoskeletal tissue healing. So dexamethasone was given 5 to 9 days post an injury. And we can see here that the dexamethasone treated tendon actually had much more ordered collagen when it was healed than the saline treated model. And I'll quickly go over this because it's quite complicated, but a further study from this same group looked at dexamethasone treatment and injury as well, and then also modified the immune response by subjecting the rats to a contaminant in the form of a bacteria. This modified the T cell response to injury, in particular the population of CD3 and CD4 positive T cells, and they were able to manipulate the healing response simply through manipulating the response to an infection. So what they did is they infected previously sterile rats with Staph aureus. This changed the population of T helper cells and caused them to rise in concentration within the healing tendons of infected rats. And the beneficial effects of the dexamethasone treatment were greater in the infected rats with the increased levels of T helper cells than they were in the clean rats, showing a very clear inflammatory component to tendon remodeling. So the summary being that tendon healing is mediated by T helper cells. And why are steroids good? Well, you curtail prolonged and inappropriate inflammation, which in the end does facilitate healing. Just as a counter-argument to that, lots of reviews have obviously shown that there potentially are deleterious effects from corticosteroids in tendons, with isolated case reports of spontaneous tendon rupture, and for that reason it's not recommended that people have more than one corticosteroid injection around a tendon. A slightly separate technique here is what's known as high volume image guided injections. What they do in this technique is they inject a very large amount of saline to the peritendinous area to strip away the near vessels and new nerves. There's also a small amount of local anaesthetic and corticosteroid given. The initial study from London has been followed up now in other countries. This one in Denmark. And a nice trial here where they've compared the Visa scores in the Achilles, comparing a high volume image guided injection with platelet rich plasma and a placebo, and we can see that both techniques seem to have superiority over placebo. In terms of the Visa A score, the high volume image guided injections have a very rapid onset of action. You can see at the 24-week follow-up stage it's already started to go back down again, whereas the late response there is seen from the platelet rich plasma, but even at 24 weeks both clearly outperforming a placebo, and that's both in terms of the Visa score and also the VAS pain score. This was just one trial looking at corticosteroid injections in plantar fasciopathy. They actually gave 3 injections in this trial. or should I say up to 3 injections, however many were needed to bring the symptoms under control. And interesting result from this trial that there was no severe side effects reported. In particular, no one had a plantar fascia rupture, and again you can see how the corticosteroid performed quite well in terms of pain relief. So shockwave, again, this is a treatment advocated for the use in tendinopathy. The mechanism of action by which it exerts its effect is not clear. Again, lots of purported mechanisms, though nothing solid so far. Lots of trials have been published around the use of shockwave in tendinopathy in different tendons throughout the body, generally speaking showing a true but moderate effect. Combining the results of these together again does seem to be favourable in terms of comparison against placebo. So there is evidence for shockwave therapy, however its effect clinically again is quite weak, often yielding only a 1 to 2 improvement in the VAS score overall. So generally speaking has to be used as an adjunct with other treatments. So getting very close to the end now, just going to very quickly talk about surgery. Very interesting is the seemingly unique case of plantaris excision with the Achilles tendon, and certainly in elite athletes who often have quite a hypertrophied plantaris muscle and tendon, it seems to cause a medial impingement along the medial side of the Achilles tendon. So we can see an MRI here of a very hypertrophied plantaris in an athlete. Generally speaking, plantaris would be invisible or just a dot on the medial side of the Achilles, but you can see here it seems to be about 1/3 of the size of the Achilles, and the area of impingement has an area of paratendinitis around it, and the corresponding histological specimens there show evidence of tendinopathy on the medial side with relatively normal structure on the lateral aspect of the Achilles. So the plantaris excision has been advocated in these cases. Other trials done on tendinopathy, this was a treatment in lateral epicondylitis. Good quality study this, blinded and prospective, where they used sham surgery as the control. And interestingly, the sham surgery fared almost as well as the surgery itself. Some evidence there that the surgery may actually be working through a placebo mechanism. The surgery isn't complicated. They simply debride the pathological area of the tendon and suture everything back up and allow it to heal. This was a less powerful study, a retrospective audit of one surgeon's experience in patellar tendinopathy. Again, similar surgical technique, reporting good outcomes from surgery, but no control group to compare with. So that really concludes my lecture today. In summary, tendinopathy, there is evidence of effect for many different treatments. However, a sensible progressive loading plan is still the gold standard. And unless that's followed, people always will fail quite quickly on resuming intensive sport. The future may hold novel biological treatments such as the use of tenocytes and stem cells, and importantly, try to avoid the use of non-steroidals and corticosteroids if you can. Many thanks for listening today. These are my contact details.